Great to see everybody tonight. Again, I see some familiar faces. Thank you so much for being here. We're going to give it just a few more seconds. It's just now 6:02. So let me get my windows here in place and we'll get started. So hello, everyone. Welcome to this week's community update. I'm Cindy Vosberg, Crescent City Del Norte Chamber of Commerce Director, and as always, honored to be here with you again tonight. Tonight, we'll be hearing updates from Dr. Stutz, our Del Norte County Public Health Official, and Del Norte School Superintendent Jeff Harris. Sutter Coast representatives won't be here tonight. However, they have given Dr. Stutz their slides and they will be presented and you'll hear the updates. I'd like to thank both Dr. Stutz and Superintendent Jeff Harris for being here with us tonight and all the other panelists. We will have time for a few questions and answers after the updates. And our goal is to get you out of here a little bit earlier than 7, and we'll see how that goes. We will continue to monitor the situation in the community and schedule future meetings as needed. Before we start tonight's program, I'd like to remind our area businesses and nonprofits of next week's town hall meeting with Senator McGuire, Thursday at 5 p.m. And the topic is business and COVID. The link to register is located on the Chamber's Facebook page, or you can email me at director@delnorte.org, and I'm happy to send you the link. The Chamber also still has surgical masks, N95s, and hand sanitizer for area businesses. Just let me know what you need, and we're happy to have them ready for you to pick up, or I can drop them off to your business. Call the Chamber at the office at 464-3174, or my email, director@delnorte.org. And once again, I want to stress the importance of us being united against the virus and not against each other. Regardless of our personal beliefs, together we are stronger than alone. We are in this together, and together we can beat it. And with that, let's turn this over to Dr. Stutz.
Thanks, Andy. So I'm going to start with the data that Mitch and Ellie provided for me from the hospital, and these are their slides. So I'm going to share my screen here. So this first slide, I really like this slide actually. It demonstrates the total number of hospitalized patients since, well, I think the surge had already kind of started back in August. This is late August until the current date. And the blue lines are the total number of hospitalized patients. And the orange line there is represents the number of COVID patients or hospitalized COVID patients. So you can see that more or less, depending on the day that you're looking at, roughly anywhere between 30% and 70% of the total hospitalized patients at the hospital are there because of COVID. And I wanted to stress that that's a really unusual thing to have happen at a hospital. I've never seen in my career half of a hospital or even a third of a hospital comprised of one infectious disease, people who are there for one infectious disease. So it's pretty unusual. The next slide, I think everybody's seen a similar slide in the past before from Mitch. And this would be, since August 1st, the total number of hospitalizations, patients in the ICU, and vented patients who are here for COVID. So this is the total number from August 1st until the present date. And then their vaccinated and unvaccinated status, as well as their age over or under age 65. And again, you can see that the majority of the hospitalizations, ICU visits, and patients who are the most critical on a ventilator are unvaccinated. When that ranges anywhere from 84 to 95%, as you can see, the most critically ill, got 5% unvaccinated on a ventilator since the beginning of August. And I like this, I always like this slide because it also demonstrates the number of people over age 65 and under age 65 who are hospitalized. And you can see there that actually it looks like the majority of people who are hospitalized are actually under age 65. And the majority of the very ill, like, because everybody's so worried about how well does the vaccine work, is it, how many breakthrough cases are we seeing? You are seeing some breakthrough cases, 6 ICU patients who were vaccinated, you can see there, and 1 vented patient who was fully vaccinated. But it's interesting to note every time I see these slides that when vaccines don't work, when there's a breakthrough case, for the most part, they're in patients who are over age 65. And that's not a surprise. That's why the FDA just this week recommended that we offer booster shots or supplemental shots to people who are, of a certain age and who have comorbid conditions, because they may not form the immune response that you'd expect to the vaccine. And you can see that right here in the data that the vaccinated breakthrough cases, many of them are over age 65. And then this is today's data. You can see that there are 14 patients in the hospital today with COVID. Again, majority unvaccinated. There are 5 patients in the ICU, which, if you remember from previous weeks, is significantly down from prior. And then vented patients. Actually, can't see that part of my screen. One sec. So vented patients, there's 2, both of them unvaccinated. When numbers get this small, analyzing the data becomes a little bit difficult, just because there are so many transient outliers. And then these are all the deaths that we've had from COVID since the beginning of August in the hospital. So just in hospital, not total deaths for the county. And you can see we've had 2 vaccinated deaths. Both of those deaths were in age 65 and older, right? So again, demonstrating that when the vaccine doesn't work, for the most part, if it doesn't protect you from a hospitalization or a death, it's usually because you're immune compromised in some way, whether it's because of age or some immune compromised state. So, and then to reiterate, the clinics, the drive-through testing, and the monoclonal antibody treatment that's available. That's going to be available through August or through October, is my understanding. The state provided monoclonal antibody therapy clinic, and after that, it'll probably still be offered from the hospital itself. So that's it for the hospital-wide data.
Okay,
And
great.
I'm going to share the county-wide data that I have. All right, oops, that's the same one. There you go. So took the data from my presentation last week and added on this week's data. So here you can see that again, the testing positivity rate is trending down. 6% looks a lot more normal than the 15-20% that we had several.
We're still seeing the cover. We're not seeing your next slide.
Oh, let's see.
There we go. All right.
Let me try again.
Okay.
I don't know why that didn't work.
It's Zoom.
How about that? Can you see that?
That's beautiful. Thank you.
Yeah, so testing positivity down a couple of points. Average cases per day down again this week, although we don't again have the full week's data. It's Thursday. So down to 17 new cases per day from the previous 26, which is significantly down from our peak at somewhere around, gosh, I think we even got up into the 50s or 60s per day at one point. Number of hospital admits per day is down slightly, maybe not measurably from the previous week, and that's to be expected because the hospitalizations always lag behind the new cases. So I'm not surprised that we didn't see much of a budge in that. And then the number of ICU patients is down again another couple of points. Three patients per day admitted to the
Dr.
ICU.
Stutz, I'm so sorry. I don't mean to interrupt you again, but could you speak up just a little bit? Some
Sure.
folks are having a hard time hearing you.
Yeah.
Okay, thank you.
Yeah, and then the vaccination rate, we're up
There you go.
another point again today or this week. So just creeping up at a point per week is about what we've been averaging. And then partial vaccinations are down again. So this indicates that our vaccinations are slowing down, right? They're not likely to get much greater than a point per week. So it says my sharing is paused. Can you guys see this? Okay.
Which one now?
These are the COVID related deaths. I just shifted this slide. Yeah.
No, we're not seeing it.
Okay. Try again.
There we go. Well, yeah. Okay.
So we had, I think I announced that we had last week, we had 2 deaths that were reported as COVID deaths. We've had one this week in hospital. One of those deaths from last week, I reviewed the case. It doesn't seem so obviously COVID related to me. The patient was diagnosed with COVID, but it was over a month ago. Had many comorbid conditions and then ended up in the hospital, this month. And the coroner ruled it a COVID death. I wasn't so convinced, to be honest. So I'm trying to gather more data on that death and decide whether or not it should be called a COVID death. So don't be surprised if any of these numbers change as we get new data coming in about who died where and how. And that's it for the county level data.
Great. Thank you so much for that information. And then Superintendent Harris.
Absolutely. Well, thank you, Cindy. So I just kind of want to start off doing the same sort of data view. So if we go to the school district website, are you seeing the website there, Cindy?
Yes.
Perfect. If you go to the school district website, click on families, you can also go to dnusd.org/family resources. And it will take you to a page similar to this, or to this page actually. And here you can click the COVID-19 dashboard. And kind of like Dr. Stutz was talking, we've seen a significant decrease. I think we were closer to 30 last week in the current number of positive cases that we had with students. This week, as of Tuesday, we were down to 13, and we have 7 positive staff members. Again, like Dr. Stutz said, as time marches on and students fall off of this because they're back from quarantine, they no longer count as a positive case, we'll see fewer and fewer positive cases on that screen. And that's exactly the direction that we want to go. The same thing with our staff. So the mitigating efforts that we've done within our schools, within our community, have been working. That does include, and I'm just going to throw it out here, I know that some people don't like it, but I think that also includes the additional mask mitigations that Dr. Stutz has put into place over the past few weeks. And within our school system, we've been very, I think, cautious as we've moved into the year, because we've tried to keep our campuses as closed as possible. We've tried to keep our students as safe as we possibly can, because really when school first starts, students are bringing with them everything they've accumulated over the summer. And so to see 3 or 4 weeks in that we're at 13 positive cases with students, 7 positive cases with adults, that still only brings us in our total school population to I believe it was 0.49 or 0.48% positivity rate, which I think is huge. So we just want to encourage families to continue to keep your child home if they're symptomatic, test them or have them tested, and then if they're negative, allow them to come back to school. And we'll continue to communicate with you. Now, I am going to share that screen one more time, because I do want to show families also, or remind families that the information around contact tracing, The information around how we determine close contacts and how we communicate with families is all on this page. So we want to make that very clear. We are going to be adding one new component to this because we've gotten a lot of questions about testing requirements. And again, Cindy, just because I know we've been having some difficulties, are you seeing the COVID testing for schools?
We are, yes.
Perfect. So we just want to be very clear. We've been working with our public health office for initial positive cases. We're most definitely accepting PCR tests or rapid antigen tests that are being provided by trained providers within our community. However, if you are doing a home test, we'll accept that too. But in all three situations, if it's a positive case, we need documentation. So what that means in the case of a home test, that means maybe a photo of the positive test and then sending that photo to your child's school so that they know that the test was taken, the date the test was taken, the name of the child that the test was performed on. And that now becomes part of our record that we share with public health so that they're also aware of that positive test. And if you are using a home test and your child tests positive, we recommend a follow-up PCR. Now, again, that's for an initial positive, right? That's right here. Where some of the confusion is coming into play, though, is for our students who have been identified as close contacts and are at home. CDPH, California Department of Public Health, does not recommend using home test kits for existing quarantine. So if your child is currently under quarantine as a close contact, we are requiring that any test that you provide us comes from a trained tester at a recognized testing location. Again, this can be either rapid antigen or PCR. Documentation of the negative test has to be provided to the school prior to your child returning. I won't go into all of the language here because it can get relatively complex, but just know that an initial positive case, we will be accepting home rapid antigen tests with documentation. For close contacts, we are not accepting home test kits. And then there's some other messaging on here too, but we'll be posting this on our website. Our principals have already been brought up to speed on this, and they'll be sharing this with families as those questions are asked.
So Mr. Harris, can you explain why that is? What the difference is between that close contact and the positive test? As far as why the difference in what the health department is recommending.
So, and actually Dr. Stutz might be able to step into that a little bit more from our perspective, because the county is in surge mode at this particular point in time. There's a surge protocol. So the Del Norte County Department of Public Health is actually accepting the rapid antigen tests that are being self-reported by folks at home. And because they're accepting that, we're accepting that as well. We have a shared spreadsheet with public health that we document positive cases on so that public health can see what that looks like, and they're aware of those cases and they can do any tracing that needs to be done. And I will throw out the caveat again, but we need that documentation, that photo with the information attached to it. But again, Cindy, because we're in the surge protocols at this point in time, that's the only reason that we're accepting the home-based test as the initial presumptive positive. And we're still recommending a PCR because we actually have found students who have a positive test at a home kit, but then they get a PCR and it comes back negative. So we want to make sure that families are aware of that second step, because when that negative comes back on a PCR, that child is no longer now necessarily required to quarantine the full 10 days. Once we get a negative PCR, they're able to come back to school 24 hours of being symptom-free with no medication. And families don't have to plan on that full 2-week quarantine. The close contact piece, that's
Uh-huh.
a child that's not positive, but was identified as being within 6 feet of that child for more than 10 minutes over 24-hour period. So that close contact, again, when we talk about exiting tests or we talk about minimizing the quarantine period, CDPH does not recommend those home tests for that. And so we are not accepting the home test for that. That has to be done by a qualified, trained individual at a location who's providing that service.
So let me ask you a question in follow-up with that has just come in. And that is, if a child is home on quarantine because of close contact, why do they need to supply a negative test?
They don't. Well,
They don't.
well, so let me back up.
Okay.
So there is a component in contact tracing and in quarantining under the new K-12 guidance from CDPH. So if your child is sent home because they were a close contact and they've been home for 5 days and they're still symptom free on day 5, you can have them tested on day 6 or day 7. And if they're negative, they can come back to school on day 8, as long as they're symptom free and they've tested negative. Now remember, a full quarantine is 10 days. So what this allows, it allows for a child to come back to school 2 days early.
Okay.
So that's where the negative test comes in. If, however, a parent cannot get a test or chooses not to get a test, then the child is just out for the full 10-day quarantine.
Okay. All right. So did you have anything else that you wanted to include in your update? I have more questions for you, but I don't want to cut you off from information you want to push out.
I'm good for there. We can jump into questions.
Okay. All right. So I'm going to stay with you for the next couple questions. Okay. So one of them is, what is the school's plan once the rainy season starts and rainy day schedules, as far as being able to, how will you avoid having so many children together in small spaces?
So again, what a lot of our schools have already started doing is separating lunches, and they've already started thinking about separating classrooms and separating rooms where they can break up groups of students if they have to go inside. Now, we want to avoid staying inside as much as we can because we want to give our students mask breaks. We want to give our students time to breathe fresh air without fabric or cloth in the way. So we're going to, really have to think about when we cancel an outdoor recess. Like I said, our principals are already thinking about already in the process of separating groups of kids that are going to eat to minimize the size of those and then further break them apart by going into classrooms. Schools have rainy day schedules that are different than regular day schedules. And so don't try to overlay what it looks like today on what it may look like on a rainy day, because those are different. However, I do want families to be very aware that CDPH does require that whenever students are indoors, regardless of the reason, they are required to be masked. So students will have to be masked, which is why we do want to look at these mask breaks. We do want to think about minimizing when we call rainy days at school sites.
Okay, so this next question actually ties in with that perfectly. And that is, why do kids have to wear a mask during recess? And I'm going to continue the question because it may, so they said elbow to elbow with masks off for 15 plus minutes while eating breakfast and lunch, but they cannot run around the playground with masks off. That was a question.
Yeah, no, and that's fine. So, one of the things that we were doing as we started the school year, like I said, we wanted to start the school year with a little bit of caution. And Dr. Stutz had come out with the masking requirement. So as we were thinking about what does it look like on our school sites, how are we going to implement what's going on right now in a surge that was massive, right? Over 400 people locally with COVID.
Right.
We're sitting here and we're thinking, how can we protect our students? And so neither CDC nor CDPH, and quite honestly, not even Dr. Stutz's order, required students to be masked outside during recess. What we did though, was we said if our students outdoors are not if they can't maintain 6 feet of physical distancing, we wanted them masked. And again, that was part of our just like the county has theirs, we had our surge protocol. When students are eating, we can't expect a child to wear a mask when they're eating. But if they're outside and they're just standing together in a small social group and they're this far apart as they're talking, then there are mitigating factors that we can put into play, especially when the rate of transmission was so high locally. And we fully expect that when Dr. Stutz pulls back the masking requirements that were put into effect because of the surge, that we will also pull back those other masking requirements to be in line with CDC and CDPH.
Great, thank you so much, Mr. Harris.
And also add to that real quick. So everybody always said, when they're asking about masking and, oh, well, they're not masking while they're eating, so it's just all worthless. Why are we even wearing masks at all? Well, the easiest way to answer that is by saying that at some point during the day, when somebody contract COVID, they contract COVID at one instance during that day, right? From somebody else who's got COVID. If they happen to be wearing a mask at that time, they are much less likely to actually contract the virus, right? So if you're wearing a mask 90% of the day, you're protected 90% of the day, and that other 10% of the day, you're not protected. It's a continuum. It's not an all or nothing. It's not worthless if you don't wear it some parts of the day and you do it during others. The more masking we have, the fewer cases we will have. It's a continuum. So that's the answer to that.
Thank you. So right along in that theme of masks, one of the questions which just has come in tonight is, how much longer will mask mandates continue?
Yeah, so once I see the average cases per day come down to somewhere around the pre-surge levels when we weren't wearing masks, as well as the positivity rate, as well as our 7-day rolling average, if our CDC level of transmission can come down to a much more normal level, then that's when I'll take the masking mandate away.
So I guess it's going to depend on this community and how well we're able to control the virus.
Yeah, so we should. Okay. Yeah, so again, we should stay the course, because again, we don't know how much of our population is going to continue to be susceptible here in this current surge. The virus is unpredictable. It could go away tomorrow and leave us alone for another few months, or it could continue on. So until we see those numbers come down, we're just going to stay the course.
So staying with the mask topic, one of the questions that came in today was, Dr. Stutz, I was under the impression that all people, whether business patrons or employees, inside any enclosed spaces were required to be masked. Are there exceptions? Are there private business owners, business owner discretions, and who is responsible for enforcement? Can a business be fined?
There are exceptions listed on the order. You can go to the order and read the list of exceptions for masking. It's not based on one business or another. It's based on physical ailments, right? If you can't physically wear a mask, if there's some reason you can't physically wear a mask, then you don't have to. It's in the order. But businesses should be masking as well as their patrons. The health department has no physical ability to enforce, really. But if we received multiple complaints about a business or an employer, we would approach that business or employer. And in the past, I've sent letters to businesses that were not in compliance. If it's a really egregious thing, then technically speaking, we can fine the business or an individual responsible for that business. I think the order states that it's technically a misdemeanor. So.
Okay, great. And so just for the business owners that are in this meeting, again, we have N95 masks. Cal OSHA and the state health department had issued the chamber some N95s so that employees who were not vaccinated and are working in same spaces as employees who are vaccinated, you can require your unvaccinated employees to wear an N95 if they're able to. And so if you need some of those, or if you want more information, next Thursday at 5 o'clock, we will have the state health department there to answer some questions, as well as the fair housing and employment. So you'll reach out to me and I'll get you the link for that meeting. Okay, so we're gonna, Dr. Stutz, we're gonna stay with you. We have some questions here, the next 5 or 6 that will actually be for you. So when and how can over 65ers get a booster shot? And do you just make another appointment at the same facility?
So depending on if that facility has elected to provide the supplemental shots or the booster shots, yeah, I would call ahead and see if they're willing to do that. So at this point, the FDA has approved it for people with certain ailments and people over a certain age, right? And then the CDC, the ACIP, has approved and made recommendations, and now it has to come to our Western States Collective, which was formed at the beginning of the COVID pandemic to evaluate the efficacy and the safety of independently of the FDA and the CDC, right? So now our state level people are going to take a look at it, and then it will be formally recommended to those patient populations. But that doesn't mean that physicians can't right now give a supplemental shot or a booster shot to their patients, because physicians, the ultimate control rests with your physician. They are fully allowed to give you a booster shot if they feel it's in your best interest, and I feel that many of them probably do. I think that the age groups and the restrictions on certain medical conditions may go away. We may have more data in the future that demonstrates that every 6-month supplemental shot or booster shot, even if it's the same shot that you received 6 months ago, might protect you a little bit more than not. And I think we are going to see some of that data here soon. The FDA didn't think that they saw enough of that to recommend it for the general population. But that again doesn't mean that your physician doesn't think so. So if you think, it might help and your physician thinks it might help, that they're it's fully within their authority to give you a booster shot. So you should ask your physician.
Great, thank you. So another question is, can you address the fact that there are a lot of people who have had COVID and are immune?
That's true. There are a lot of people who have had COVID and are now protected, right? Not immune, but protected. Yeah, I mean, they're immunized, right? In a sense that they are protected in some way. But that doesn't mean that they're 100% not going to get re-exposed to COVID or get reinfected with COVID, right? So, I mean, any communicable disease is like that. There are always some breakthrough cases in people who have been sick before. Flu mutates, every year in multiple different ways, and we know that now that COVID mutates pretty rapidly. So I would reiterate what I think I've said several times before in these meetings, in that your best level of protection from the data that we have now is having had it before, having had COVID infection before, and having a subsequent vaccine. That you'll be far less likely to end up in the hospital or dead from COVID if you have those two things.
Okay, so another question that we have here is, Dr. Stutz, in the past couple months, COVID-19 cases per 100,000 are much higher than in surrounding counties compared to California and Oregon. What factors led to so many COVID-19 cases here in Del Norte County?
Yeah, I mean, some of it's obvious. I mean, our low vaccination rates at the time, and probably, low adherence to masking guidelines and things like that. Rural counties across the Western United States and elsewhere got really hit hard by the Delta variant, and I think part of it was because of the lower vaccination rates. And there's a component of unknown to this virus that is just probably because all eyes are on this virus, and we're analyzing the data so closely, and we have been for a year and a half, unlike any other infectious disease that has plagued our populations in the past. We have all this data and all this access to all, and it was so scary at first that all eyes were on all this COVID data. So we're sequencing, for variants and all this stuff that doesn't normally happen with other infectious diseases, because none of those things were such a threat to our survival, potential threat, as this one that we had never seen before. So there's an element of mystery to the disease that might just be the fact that we've never studied a virus this closely before. Maybe a lot of viruses mutate quite like this, quite quickly. They just don't happen to kill as many people. That's why we're so interested in this one. So, and it seems to strike different areas of even the same state or the same county and at different frequencies, and we just don't know why. It'll blow up one skilled nursing facility right next door to a hospital, and nothing will happen. And it's just very strange. It's been like that since the beginning of the pandemic. One variant or another didn't really seem to matter. It just almost at random sometimes seemed to explode in different areas. So it's really hard to say.
All right, thank you very much. So we have a question here, which is Dr. Stutz, is herd immunity a real thing? What is it and how is it achieved?
Yeah, so that's a great question, actually. Herd immunity is probably a realistic objective for some communicable diseases. Well, I mean, so we have on the one end of the spectrum, right? We have polio, right? Something that's been eradicated forever now from the human population, except for there's one version of polio that still causes paralysis as a side effect in some third world countries, basically, that the WHO has been working on, and we've been working on eradicating that, and very close to eradicating that from history forever. So that's an example of herd immunity that worked great, right? We vaccinated enough people that it wasn't being transmitted around from person to person, and it's gone now. One step below that would be measles, right? So measles used to be, for most people, for most kids would get measles and they'd be really sick for a while, and then they'd get better and it wouldn't be a big deal. A certain percentage of them would get really sick and die. They would get some neurologic deficits. Some of them would fall ill to bacterial pneumonias after measles because of their weakened immune systems. It was enough deaths of pediatric patients that we decided to go after this disease because it was very disturbing to the human population, right, when kids die. So worthwhile going after. Herd immunity was achieved for a very long time. Probably by the 80s, I think we had herd immunity in the United States, and we were seeing very few cases of measles every year. And herd immunity was working great. And then vaccine rates started to drop off, and measles was reintroduced into the population. And now we're hovering somewhere around the border of herd immunity. Like, most of us have never seen a case of measles or been infected with measles, but we know it's out there. So there's some examples of herd immunity that's worked great. And measles, by the way, is about as infectious. The Delta variant is about as transmissible as measles. It's one of those respiratory transmitted diseases, right? So for some perspective. So is Delta variant, is COVID, is that a realistic objective that we might be able to get herd immunity? Well, I mean, if we can achieve vaccination rates that we did with MMR against measles, right? Which was very high. It was like 80 and 90% of the population had been vaccinated. So maybe if we can achieve those levels of vaccination, maybe herd immunity will kick in. But again, will it be that way next year when there's a new variant of COVID that comes through and breaks through all of those? So measles is the thing where you can get a couple doses and booster shot when you're a kid, and pretty much protected for life. Not every virus is like that. Not every infection is like that. So COVID just may be one of those ones where we need a yearly booster, like influenza, right? We would have, with those kinds of diseases, we would have to achieve very, very high vaccination rates to get close to herd immunity, where people just aren't transmitting it and it's not endemic anymore. So I think I'd say unlikely that we're going to get there at the rates of vaccination that we have going on now and all the resistance that's been shown towards vaccination. I highly doubt that we're going to get to a state of herd immunity in most communities in the United States. It's an endemic disease now. It's probably never going away unless we can get more people on board with vaccination by some miracle. Just like influenza, it's going to be around for a long time until we figure out some other approach.
Okay, so I have a couple more questions for you, Dr. Stutz, and Mr. Harris, I have one more that I am going to ask you that may have come in before or after your last question. But so Dr. Stutz, is mandatory testing on the horizon for anywhere other than the schools?
I wouldn't really be in support of mandatory testing per se in an environment, unless we're in an environment where the population has a high burden of COVID, like we do now, right? So our positivity rate is high, our new cases per day are very high. That means that's called prevalence, the prevalence of a disease in a society, right? The number of people who currently have the disease and can give it to other people, right? And so when the prevalence is high, it changes the test characteristics. It actually changes the efficacy of the test. And it's a basic principle of modern medicine, is understanding the statistics behind the tests and what they mean, and when they're wrong and when they're right, how to interpret them. So in a population where the prevalence is very high, those tests become more accurate. A positive means more. A negative test means less. You could be wrong more often. A positive test means more. You could be right more often. And so in this kind of environment where we're in now, where the prevalence is high, I do recommend random screening tests, right? Or any program that implements more testing is more likely to have true positives come out of that testing program. It's more likely to represent reality, right? If we go back to a state where we don't have much COVID at all, I don't recommend more screening, because we're likely to have more false positives, right? Or false negatives, right? So it's not going to be as accurate. And so those are my feelings. I don't feel like mandatory testing is coming down the line for other industries, unless businesses and private entities decide to do it for their own employees, which they fully can do if they want to. But again, from the state guidance is usually done under pretty strict physician control. Physicians who understand the statistics of tests are making these testing guidelines, right? So generally in that case, most modern physicians don't just recommend random testing in a low prevalence population. So hopefully that answers your question.
I think it does. Thank you. So, Mr. Harris, I have a question for you, and then I'm going to come back to Dr. Stutz. So, Mr. Harris, the question came in: how come outdoor sports are not required to wear masks, but our young children who are very active at recess are?
So that was a clarifying conversation that I had with principals. And I said it earlier tonight, is if they're outdoors, unable to maintain that 6 feet of distance, and they're in social groups, then the masks need to be on. If they're playing, if they're running, if they are, like Dr. Stutz said, it's a continuum about how often and the frequency of those close contacts. If they are running and they are playing and they're not right in front of one another, then they shouldn't have the masks on during heavy exertion. And that bears itself out in a lot of the literature as well.
Okay, great. And so if a parent is concerned and they feel that at any particular school that their child is still being required to wear a mask while they're playing at recess, they should reach out to the school principal or the teacher. How would you recommend that they communicate that?
Always start with the principal.
Okay.
They'll have more information than anyone else at that particular point in time. And then if either the answer is unsatisfactory, or if it seems that it's not in alignment with kind of what we're talking about tonight, then you can feel free to give my office a call here, 464-6141, and you'll be given to the person that can help you.
Great, thank you so much. And then Dr. Stutz, we have one final question, and it's a little long. I'm going to go ahead and read it. And so it's been asked in the past, at least a couple weeks ago, and Mitch Hanna had answered it, but we're going to go ahead and throw it at you tonight, which is I test positive for COVID, I go to the hospital. Do you admit me? If not, what care do you offer and what do you prescribe for my COVID condition? What medications, specifically what antiviral medications? If you do admit me, how do you treat COVID? What will you prescribe immediately to fight the infection? And what antiviral drugs will you use or can you administer? And then Dr. Stetz, if you can talk about some of the different treatments that are offered and how we're using them here in Del Norte County and specifically at Sutter Coast Hospital.
Yeah, so question has sort of been asked several times before in different settings, but yeah, there's a whole subgroup of people who really believe that ivermectin, hydroxychloroquine, and all these other candidates for antiviral therapy might work for COVID. I say right off the bat that hydroxychloroquine was debunked last year sometime. The data has never supported the use of hydroxychloroquine. It's not a cover-up. This is from many trusted sources in evidence-based medicine have debunked the use of hydroxychloroquine in COVID. It doesn't help treat it. It doesn't prevent it. It doesn't make you feel any better even. So nobody who pays attention to the literature at all is using hydroxychloroquine ever for COVID. There are probably people prescribing it for money, but nobody's actually believing that it's treating COVID in any real way. There are other drugs out there like it, and I'm just going to address the other one that's been really popular is ivermectin. There are many international studies that support the use of ivermectin for COVID prevention and treatment. However, they are not up to the standards of the study design that US physicians are accustomed to interpreting and backing the data behind the medications that they use. So they were done all over the world in many different settings, and some of them were randomized controlled trials, some of them weren't, some of them were poorly controlled, some of them didn't have enough patients, some of them were flat out falsified, and some of them are probably legitimate. So there was a meta-analysis that everybody quotes where they compiled all these studies together and they showed a benefit for ivermectin. That might be the case. There might be a benefit for using ivermectin in cases of COVID. However, because the studies that were amalgamated into this meta-analysis weren't up to snuff, generally speaking, most physicians in this country don't believe that ivermectin will have a significant enough effect. There are several studies in the clinical trials database, however, that are currently ongoing in the United States that were well designed and designed to answer this question. And they aren't resulted yet, and we'll know more probably, I'm hoping by the end of the year, we'll have that data to refer to. Maybe ivermectin will work, maybe it won't. But I'm waiting on those studies to really make up my mind. Ivermectin does have some apparently antiviral effects and anti-inflammatory effects, in addition to being an anti-helminthic, which is it's an anti-parasite drug. However, the data for most physicians, the data just is not good enough to routinely prescribe it for patients. Although there are physicians who are perfectly respectable physicians in hospitals across the country that are giving it to people. And if you got admitted to, or even if you got sent home from the emergency department with a diagnosis of COVID, you might get prescribed that if you demonstrated an interest in it and if your physician was interested in giving it to you, So that's on a physician by physician basis. And I wouldn't fault any physician for prescribing ivermectin, given some of the positive data that we've seen. That's up to them. Again, that's their prerogative. What else might you be prescribed? Well, if you got discharged or admitted with a diagnosis of COVID and you fell into the right criteria, you would probably get monoclonal antibody therapy, right? So you would get Regeneron or one of these other monoclonal antibody therapies that are provided as an outpatient or sometimes an inpatient in the hospital. That's a type of immunization, right? It's not a vaccine, but it's a type of immunization insofar as it provides you with antibodies that you didn't have yet. to the virus, to sort of, when the antibodies, are proteins that float around in the bloodstream, glom onto the viral particles, and then they're destroyed, right, by your immune system. So that's another drug that you would receive. You'd also receive oxygen if you're hypoxic, and oxygen is considered a drug. So you would get oxygen therapy in the hospital, and you would also receive all of the mechanical therapies that we would give somebody with COVID in the right setting in the hospital. For example, if you just couldn't run the marathon anymore and you couldn't breathe anymore because you're too hypoxic and you're too worn out from breathing, you would get intubated, right? And you put on high flow oxygen. We use a technique called proning too. So it's not just about the medications that we're giving. We're proning you on your stomach, right, rather than laying on your back, to help expand different parts of the lung and help oxygenate you. There are other techniques that respiratory therapists use, suctioning, right? You would have an IV, you would have your fluid balance measured daily, and your temperature, and we're monitoring in the ICU. That's what we're doing. We're monitoring fluid, temperature, body hemostasis, all these vital signs of things that we're monitoring and adjusting as we go. Your blood pressure, do you have a bacterial infection on top of your COVID infection, which sometimes happens, right? Then you're really in trouble if you get a pneumonia, bacterial pneumonia on top of your COVID. Then we can give you antibiotics, right, against your pneumonia. So it really depends on the case. But there are a lot of therapies other than just medications and treatments, right, that go into your care once you enter into the hospital with COVID, depending on your severity level.
Okay, great. Thank you. That's a very good detailed answer. And I know I said that was going to be the last question, but I'm actually going to toss one over to Mr. Harris, and then we're going to go ahead and close out tonight. As I mentioned in the beginning, we'll be monitoring the health status of the community and calling the next meeting as needed. You can watch the city's Facebook page, the hub, the Del Norte Office of Emergency Services hub, the county health department hub, for when the next meeting will be in the link. And so, Mr. Harris, one last question, and is that they were requiring football players on the sidelines to mask. Has that changed?
No, that is a California Interscholastic Federation rule, is that when students are not competing, they have to be masked. So that is part of the requirement statewide for students to be able to compete in CIF.
Great, thank you very much. I want to thank you all for being here tonight. I want to thank everybody who's attended and those of you who have attended every week. We appreciate your need to know what's going on and hope that we're helping to answer some of your questions. I want to thank our panelists and especially Superintendent Harris and Dr. Stutz. I think they've done a great job of trying to answer your questions and your concerns. And, hopefully the numbers will continue to decrease. And if they don't, then we'll be here again to meet with you and answer your questions. Thank you so much. And Mayor Grinnell, thank you so much for being here with us as well. Thank you all.
No problem.
Go ahead. Would anybody like to say anything?
Well, I just wanted to thank you, Cindy, as well as Dr. Stutz and Superintendent Harris for being here for all of these meetings. I know it can get grueling sometimes answering these questions over and over again. But thank you so much for stepping up and for all the work that you've been doing through this surge. You've made a difference. I truly believe that. And I want to thank your staffs as well at the hospital, as well as public health and at the school district for all their work. All of us pulling together in the same direction, we're going to get past this and we're going to be stronger for it. So thank you again.
That's right. We will get past this. This too shall pass. Thank you, Mayor. So thank you, everybody. And we'll see you on the other side.